am Professor Patrick.
Professor?
Dr. Professor Patrick.
Welcome back to the Internal Medicine Case-Based Review Series. We're going to move on to nephrology at this point. So after this review, you should be able to interpret common causes of dysuria and sexually transmitted infections, differentiate nephritic and nephrotic syndromes and devise their causes, indicate causes of acquired and inherited acute and chronic kidney disease, identify common urinary sediment microscopy findings and classify their associations, and contrast different renal neoplasms in their presentations. So we're going to start from the end of the urinary tract and move our way towards the beginning. So starting out with cystitis, we have a 21-year-old sexually active female complaining of burning during urination. She also has pain in the lower abdomen and increased urinary frequency. So her vital signs are temperature of 37.1, normal BP, normal pulse. She has mild suprapubic tenderness on exam, but otherwise negative. She has no costovertebral tenderness, no vaginal discharge or masses. So the next best step, if you have a patient like this, is urinalysis and culture. So on urinalysis, if you see WBCs but no cast, that's going to be more indicative of cystitis. And then urinary culture, the definitive step is greater than 1,000 colony-forming units. So the most common causes of cystitis in young, healthy women is going to be E. coli and Staph saprophyticus. So catheter-acquired and healthcare-acquired cystitis infections can be caused by Enterococcus, Klebsiella, and Pseudomonas, some of those bad bugs that love growing on artificial substances. Treatment is usually going to be trimethoprim sulfamethoxazole if there's no contraindications, nitrofurantoin, or second line now is ciprofloxacin. So in pregnancy, you can do nitrofurantoin, amoxicillin, or cephalosporins if needed. Moving up the urinary tract, pyelonephritis is going to be a 76-year-old woman presenting from a nursing home for fever and nausea. She's immobile at baseline and has a urinary catheter. Vital signs are temperature of 38.7, pulse of 118, BP of 108/67, and respirations of 20. On exam, she has flushed skin, lower abdominal, and flank pain. The next best step again is urinalysis and culture. You can also do a CT scan and it may show perinephric stranding. The common bugs for pyelonephritis are E. coli is the most frequent cause. And then because this is a catheter-associated infection, Proteus, Klebsiella, Enterobacter, Pseudomonas, and Enterococcus are all possible. So some of the risk factors are having vesicoureteral reflux, an indwelling catheter, being a female gender, or pregnancy. Some of the complications, as in this case, we have a urosepsis and shock picture. There's also emphysematous polynephritis in diabetics. So treatment, again, trimethoprim sulfamethoxazole is going to be your first line. Inpatient, what's commonly used is ceftriaxone or ciprofloxacin for gram-negatives. You can treat gram-positive infections with amoxicillin or increasing if there's a Staph aureus infection or thoughts that this is a hospital-acquired infection, vancomycin. So some sexually transmitted infections to know. We've got a 25-year-old man from North Carolina presenting with a rash all over his body, including his palms and soles. He admits having a non-painful ulcer and denies being outdoors. So the reason I included North Carolina here, being that Rocky Mountain spotted fever can also present with a rash, including the palms and soles. But not being outside, not having any tick bites makes that less likely, and the non-painful ulcer makes you more attuned to syphilis. So you can screen with a VDRL, and you can confirm with FTA, ABS, or dark field microscopy. And treatment is going to be penicillin G or doxycycline if they're allergic. So if you've got a 19-year-old woman presenting with purulent vaginal discharge and swollen tender wrist and knees, on exam the cervix is friable and painful. So diagnosis would be disseminated gonococcal infections. So this can cause a asymmetric monoarticular arthritis. You're going to want to do a NAT or a DNA PCR to look for gonococcal or chlamydial infections. Joint aspiration is the next step always if you've got a hot swollen joint, and then a total STI panel. So you treat disseminated gonococcal infections with ceftriaxone and either azithromycin or doxycycline. With a NAT test nowadays, they are sensitive enough to the point that you don't have to co-treat, but there's increasing resistance with gonococcal infections, so they still recommend co-treating if it's a gonococcal infection with ceftriaxone and azithromycin or doxy. So next, we've got a 32-year-old woman who presents following a sexual assault. She undergoes a forensic examination, and labs show a positive NAT for chlamydia only. So at this point, with the NAT testing positive for chlamydia, you can treat with either azithromycin or doxycycline. You don't have to use ceftriaxone to co-treat for the chlamydia. So next up, we've got a 47-year-old man who presents with burning and pain in the groin region. He experienced these symptoms whenever he's under stress. On exam, there are group vesicles on an erythematous base with painful lymphadenopathy. So this is going to be herpes simplex. The classic, vesicles on a rose-colored base or erythematous base is what you'll see. You can confirm with PCR, or what they used to use is a Tasmac smear. Treat with oral or topical azithromycin during outbreaks. You can also prophylax if there are recurrent events with oral acyclovir. So now moving on to nephrolithiasis, we've got a 24-year-old man with severe abdominal pain that radiates to his groin in waves, as well as nausea. He noted dark-colored urine. Vital signs are temperature of 37.2, pulse of 103, and BP a little bit high. On exam, he's rolling and wincing in pain. So your next best step here is urinalysis with microscopic examination of the sediment. So you can also try imaging. X-ray is your good initial test, but it's unable to detect uric acid kidney stones or cysteine kidney stones. Both of these are radiolucent. And then on ultrasound, you can do a rapid test with no radiation exposure. It's gaining sensitivity, but it can be very specific. And then the gold standard is going to be a CT without contrast, even for radiolucent stones like a uric acid stone. So your risk factors are going to be dehydration, a diet high in oxalate, gout, Crohn's disease, hyperparathyroidism, type 1 RTAs, using loop diuretics, acetazolamide, antacids, the male gender, infection with a urease producing bacteria, because then you'll get struvite stones. And then you're going to want to treat them with pain medication, IV fluids to try and flush a lot of prerenal azotemia out, and either alpha blockers with or without antibiotics if they seem to be an infectious picture. So stones greater than 5 millimeters should pass spontaneously, or less than 5 millimeters should pass spontaneously. Stones 6 to 20 millimeters may require extracorporeal shock wave lithotripsy, and stones greater than 20 millimeters, a lot of the times your struvite stones will require percutaneous nephrolystomy. So to prevent recurrence with dietary and fluid measures, you can also use allopurinol for gouty stones and thiazide diuretics if they've got familial hypercalciuria. So all your different types of stones, calcium is by far the most common. There's calcium oxalate and calcium phosphate. So they're going to look like bipyramidal. They're very radiopaque, and there's a lot of risk factors, including Crohn's disease, hyperparathyroidism, etc. So with uric acid kidney stones, they are 10%. They're rhomboid-shaped, radiolucent, or not easily seen on X-ray films, and they commonly form in acidic urine due to gout or rapid cell death. So think chemotherapy, or a lot of the times a rapidly progressing lymphoma, leukocytosis type picture. So you have a struvite stone. They're rectangular prism or coffin lid shaped. They are radiodense and alkaline urine due to urease producing bacteria. So most commonly is Proteus. And then there are cysteine stones, which are hexagonal shape, radiolucent, and they commonly form in an autosomal recessive disease called cystinuria. So where it's stuck, the most common location is going to be the ureterovesicular junction, or the calyx of the kidney, or the uretopelvic junction. So now interstitial nephritis. We've got a 36-year-old returning to the physician with a fever, rash on her trunk, and generalized aching. She had been seen 2 weeks prior for a sprained ankle and received a prescription for an anti-inflammatory medication. Vital signs are temperature 36.9, pulse of 76, BP of 114/78. There's a diffuse macular rash on the trunk. So this almost seems like it would be a interstitial nephritis picture. So your next best step is going to be urinalysis. and you want to take a look and see if there are eosinophils in the urine. That's going to be your most sensitive finding, but there may not be eosinophils. Look for pyuria and hematuria, but a culture negative. So the causes are drugs, especially penicillins and cephalosporins, every type of sulfa medication, furosemide, thiazides, in this case NSAIDs, anticoagulants, phenytoin, rifampin, proton pump inhibitors, and autoimmune diseases. So the treatment is going to be stopping the offending agent, and then you can try a trial of steroids. So moving into nephritic versus nephrotic syndromes. So the big idea here is to differentiate between the nephritics and the nephrotics, and then once you know whether it's nephritic or nephrotic, half of the answer choices will be eliminated, and you just have to pick the vignette that matches. So if we have a 26-year-old with dark urine, swelling around his eyes, and he admits to using IV drugs and testing positive for hepatitis C, on vital signs he is hypertensive. He's got a pulse of 87 and a temperature of 37.2. So this is going to be a nephritic syndrome. So it's defined by greater than 3 erythrocytes per high-powered field. The symptoms you're going to get there are hematuria or dark-colored urine, proteinuria, but not as high as the nephrotic syndrome range, hypertension, edema, anemia, and renal failure. If we compare that to the nephrotic syndrome, we've got a 36-year-old with a history of non-Hodgkin's lymphoma who presents with puffy eyes and legs. He's noticed drinking more and going to the bathroom more frequently, and he says his urine is very frothy. On vital signs are going to be stable, non-hypertensive in this case. So your nephrotic syndrome is defined by urinary protein greater than 3.5 grams per day. So you can do that as either a 24-hour urine or a urine creatinine ratio. So it results in hypoalbuminemia, leading to edema and anasarca. A lot of the times it's perioral, periorbital edema, and hyperlipidemia because you're consequently trying to make more lipids to fill up your vasculature. So they are hypercoagulable because you're losing antithrombin 3 in the urine, and immunosuppressed due to losses of immunoglobulins. So the next best step in both of these cases is going to be a urinalysis with microscopy and a protein creatinine ratio. The definitive test, which is not often done, is going to be a renal biopsy. So if we look at nephritic syndromes, we've got a 14-year-old boy with red urine 3 days following an upper respiratory infection. So this is IgA nephropathy. It's the most common nephritis worldwide, with mesangial deposits of IgA and C3, usually 1 to 7 days following an upper respiratory infection or a GI infection. So any infection that's going to lead to IgA class type being produced, so mucosal immunity, is going to activate this, and the timeline is key. It has to be 1 to 7 days following a URI. So if we compare that to a 18-year-old man with a history of deafness and increasing oliguria with hematuria, so it's important here to see this is a male gender because Alport syndrome is X-linked defect in type 4 collagen, leading to deafness and hematuria proteinuria. So the common saying is can't pee, can't hear a bee. So deafness and proteinuria, hematuria is Alport syndrome. Now we've got a 28-year-old with a sore throat and skin infection 3 weeks ago and now presents with hypertension, edema, hematuria, and decreased complement. So this is post-streptococcal glomerulonephritis, PSGN, and this is going to occur 2 to 3 weeks following an infection with group A beta hemolytic streptococcus. So keep in mind this is 2 to 3 weeks following versus 1 to 7 days in IgA nephropathy. So now we've got a 21-year-old African American who presents with asymptomatic hematuria found on UA. She has multiple family members that suffer from bone pain and infections. So it sounds like she's got a family history of sickle cell disease, and sickle cell trait can present as asymptomatic hematuria in individuals. So you can screen her genetically. You can do an erythrocyte electrophoresis. And lastly, we've got a 47-year-old man who presents with cough productive of rusty sputum and dark urine. So it's a middle-aged man, so a Wegener's or Goodpasture's picture. You can do a C and P ANCA to look at those respectively. Goodpasture's is an antibody to glomerular basement membrane, and with either of these, you're going to be treating them with cyclophosphamide. Goodpasture's is treated with plasmapheresis, and Wegener's is treated with steroids. So the nephrotic syndromes, the protein syndromes. So a well-appearing 8-year-old child presents with foamy urine and edema. So a lot of the times, young children, anybody less than 18 with foamy urine, think minimal change disease. It's common in children, and it's due to podocyte effacement, due to T cell changes within the electron membrane. So there's an increased risk in lymphoma. So you can see a minimal change disease appearing in an older individual that has lymphoma. And your treatment is going to be steroids for 4 to 8 weeks, depending, and they usually make a full recovery. So next up, we've got a 25-year-old African American who presents with edema, oliguria, and foamy urine. So this is focal segmental glomerulonephritis. It's common in African American and Hispanic individuals. It increases in risk with IV drug use. And treatment, you can try steroids or cytotoxic agents, but usually this is progressive in 5 to 10 years to fulminant kidney failure. Next up, we've got a 49-year-old with a history of lupus who has edema and foamy urine. There is no hematuria found. So this is important. Lupus oftentimes has lupus nephritis, but specifically membranous or membranoproliferative glomerulonephritis can be related to Hep B, Hep C, syphilis, malaria, captopril, neoplasms, or lupus. So this is specific, no hematuria in lupus, and the treatment is going to be supportive. So next up, we've got a 38-year-old with a long-standing HIV infection who presents with edema and proteinuria. So this is HIV nephropathy. It resembles focal segmental glomerulonephritis, and you can treat this with prednisone, ACE inhibitors, and highly active antiretroviral therapy. And this can sometimes resolve due to HIV infection. So lastly, we've got an 87-year-old with recent pathologic fractures and pneumonia who presents with a decreased anion gap and proteinuria. So this is amyloidosis due to multiple myeloma. So this is Bence-Jones proteinuria. The next best step is to do an SPEP or UPEP, a serum protein electrophoresis and urine protein electrophoresis. And you can diagnose this with a bone marrow biopsy showing greater than 20% plasma cells. So you can treat with chemotherapy or bone marrow transplant. So the decreased anion gap is due to increased positively charged immunoglobulins in the blood, and the pathologic fractures are due to the activation of rank L. So renal tubular diseases. So we've got all 4 of our renal tubular diseases and a couple special cases. So we've got a 40-year-old man with recurrent kidney stones, and laboratory shows hypokalemia, hypochloremia, and a non-GAP metabolic acidosis. So this would be a type 1 RTA. So this is distal, and they cannot secrete hydrogen ions, and thus it presents with kidney stones and rickets in kids. You want to treat this by alkalizing the urine. So you add sodium bicarb. Next up, we've got a 36-year-old with Wilson's disease who's found to be hypokalemic, hyperchloremic, and a non-GAP acidosis. This is type 2 RTA. This is a proximal loss of bicarb due to either multiple myeloma, Fanconi syndrome, cystinosis, lead poisoning, and Wilson's disease. And you treat with sodium restriction, not bicarb. So that's how you differentiate this between type 1 and type 2, is their chloride level and whether or not they're going to get kidney stones. One gets bicarb, the other does not. So the last RTA, we've got a 76-year-old diabetic patient who's found to be hyperkalemic with a non-GAP metabolic acidosis. So this is type 4 RTA, the only hyperkalemic one, and it's due to hyperaldosteronism or aldosterone resistance in the tubules from diabetes or certain medications. Next up, we've got a 4-year-old child with rickets and failure to thrive, and he's found to have amino acids, phosphate, glucose, and uric acid in a urine sample. So this is Fanconi anemia, often hereditary, and it can be acquired by taking expired tetracyclines. And it's a disease of the proximal tubules, resulting in a type 2 RTA and a loss of essential minerals and organic acids. You can treat it with supplementation and adequate hydration. So last, we've got a 6-year-old who's found to have dermatitis, diarrhea, and dementia. Amino acids were found in the urinary sediment. So this is Hartnup disease. It's a genetic decrease in neutral amino acid absorption that causes nicotinamide deficiency or B3 deficiency, niacin deficiency. Next up, we've got renal papillary necrosis. This case is a 72-year-old man with a chronic arthritis who's taken more than 3 grams of over-the-counter analgesics per day, including aspirin, ibuprofen, and acetaminophen. He has increasing malaise, nausea, and diminished mentation. Vital signs show a BP of 166/91. So your next best step is a urinalysis, and the results are going to look very similar to acute tubular necrosis. The most appropriate diagnostic step is an excretory urogram, although that's not commonly done. So renal papillary necrosis is associated with NSAID use, diabetes, sickle cell disease, chronic alcoholism, and renal transplant rejection. The treatment is going to be stop the offending agent if it's NSAIDs and treat any underlying disorders like diabetes or renal transplant rejection. Now we've got polycystic kidney disease. So the first case is a 54-year-old with a family history of stroke who was found to be hypertensive at a health fair and followed up with her PCP. She has had vague abdominal pain and darkening urine for the past few months. Vital signs are hypertensive to 156/92, pulse of 76. On exam, there is a mid-systolic click at the apex and bilateral flank masses. A screening UA shows hematuria. So our diagnosis here is polycystic kidney disease. It's associated with Barry aneurysms, which leads to the family history of stroke, as well as mitral regurg and mitral valve prolapse, which is the murmur shown in the vignette. The next best step is ultrasound, and it's going to show enlarged kidneys with multiple cysts. Treatment is controlling hypertension, watching out for any Barry aneurysm complications, and renal transplants. So our last case is a G1 mother that has a history of oligohydramnios and gives birth to a small for gestational age newborn. Vital signs are relevant for respiratory distress. On exam, there's enlarged flank masses and a palpable liver. You could also see this as a form of Potter syndrome. So the diagnosis here is autosomal recessive polycystic kidney disease. It's associated with oligohydramnios, Potter sequence, and then liver cysts are going to be the answer usually here. So for acute kidney injury, AKI, we've got a 38-year-old admitted for crush injury. His left leg was trapped under debris from an earthquake for 5 hours. Initial labs show a sodium of 134, potassium of 5.1, BUN of 40, creatinine of 2, and an anion gap of 18. So the next best step is to do urinalysis and urine chemistry. So a lot of the causes here are pre-renal or decreased renal perfusion, either hypovolemia, hypotension, a vascular incident, drug toxicity, leading to oliguric, greater than 20:1 BUN to creatinine ratio, and less than 1% FeNA. It can cause acute tubular necrosis if the insult is not reversed. And then we have intrinsic causes of AKIs. So the kidneys are unable to concentrate the urine. Think of acute tubular necrosis, glomerular disease, HUS, TTP, AIN, cisplatin, or rhabdo in this case, leading to less than 20:1 BUN to creatinine ratio and 2 to 3% FeNA. So last, there's a post-renal or obstructive cause along the urinary tract that causes a backup of pressure. Think BPH or kidney stones. And you can treat this, or you can screen for this with ultrasound and catheter trial to relieve the obstruction before the injury. Moving into chronic kidney disease, we've got a 67-year-old man who presents for follow-up. He has a long-standing history of type 2 diabetes, not well controlled, and hypertension. He's been nauseous with loss of appetite and more tired the past few weeks. Vital signs are relevant for BP of 158/98. On exam, the abdomen is benign and a faint friction rub is auscultated. So your next best step here is a creatinine clearance and GFR estimation. So we can treat him with ACE inhibitors and blood pressure control. We want to control his diabetes aggressively. And you can treat chronic kidney disease related anemia with EPO, erythropoietin, and secondary and tertiary hyperparathyroidism when they arise. You want to make sure to measure their electrolytes frequently and watch fluid and infections. So transplant is the cure. Dialysis is a treatment, and it works okay for about 5 years, but moving people onto the transplant list is definitely a major key here. So next up, we have a 5-year later, the patient is found unresponsive at the Strawberry Festival. There's multiple dark necrotic ulcers, calciphylaxis on his skin with a white frost noticed. CPR is initiated and he's transported to the nearest hospital. So this is an event of emergent dialysis. So strawberries are extremely high in potassium, and this is probably what's led to his demise here. So your emergent dialysis are going to be AEIOU, acidosis, electrolytes like hyperkalemia, intoxication, think lithium, methanol, aspirin, or antifreeze, overload, so fluid overload in this case, you can use dialysis to remove fluid, and uremia, which he's got sort of a uremic frost and a friction rub. So lastly, we're going to move on to cast or urinary settlement that you can see. So red blood cell casts are going to look as shown on the right. They're common in glomerulonephritis and malignant hypertension. Next up, we've got white blood cell casts. So you can see these in pyelonephritis, acute interstitial nephritis, and transplant rejection. Next up, we've got fatty casts, which are in nephrotic syndromes, and muddy brown cast, or cellular degradation and acute tubular necrosis. Then there are hyaline cast in concentrated or non-clear catch UA samples, and waxy cast in end-stage renal disease. And moving into the cancer section, we've got renal cell carcinoma. So a 67-year-old man presents 6 months of progressive weight loss, flank pain, and a mass. Vital signs are blood pressure of 149/89, a pulse of 81, and temperature of 37.3, respirations of 18. On exam, there is pain and a mass on the right flank. So next step is urinalysis for the hematuria. The diagnostic step of choice here would be a CT with and without contrast. That's going to be standard for diagnosis and staging of RCC. The number one risk factor is smoking. Also, phenacetin, cadmium, mercury, and rarely there is an autosomal dominant von Hippel-Lindau disease causing hemangiomas, renal cell carcinomas, and pheochromocytomas. The classic triad for RCC is hematuria, hypertension, and a flank mass. RCC can also cause paraneoplastic syndromes like polycythemia, hypercalcemia, Cushing syndrome, or masculization. So your treatment here is going to be a radical nephrectomy and chemotherapy because RCC likes to spread hematogenously. And next we're going to go into the male genitourinary system. So the learning objectives for this chapter are going to be to classify causes of urinary difficulty and genitourinary pain in men, to identify the presentations of genitourinary cancers, and to determine acute testicular pain and the appropriate management. So starting out, prostatitis, we've got a 25-year-old male presents with complaints of sudden onset fever and chills, urinary urgency and burning on micturition, and perineal pain. His symptoms developed the day after he underwent a urethral dilation for a stricture. Vital signs are temperature of 38.5, pulse of 94, and BP of 128/89. On exam, there is suprapubic tenderness. Rectal exam reveals an asymmetrical, swollen, firm, and boggy, markedly tender, hot prostate. So your next best step here is going to be urinalysis and culture. You'll notice that's a theme for any type of genitourinary complaint. Common bugs are going to be gonococcal or chlamydial infections in sexually active or under 35 patients. In older individuals, you want to look for E. coli or Pseudomonas. And then if there's any sort of surgery or procedure performed, look at Staph aureus or Staph epidermidis. The treatment is antibiotic therapy directed at the urine culture and risk factors. Next up, we've got BPH and erectile dysfunction. So we have a 66-year-old male who complains of urinary frequency and weak stream over the past 6 months. He also complains of having to wake up multiple times during the night to urinate. On exam, there is smooth enlargement of the prostate, so you can diagnose benign prostatic hypertension or BPH. One of the common treatments is alpha-1 agonists, all the drugs that end in osin, or 5-alpha reductase inhibitors, anything that ends in asteride. You can also use phosphodiesterase inhibitors or AFILs. Next up, we've got a 50-year-old man who presents for his annual wellness exam. Right before the provider walks out the door, he confides that he has problems getting it up. He has a history of hypertension and coronary artery disease, as well as diabetes, and he's prescribed PRN nitroglycerin for his CAD. Vital signs show a BP of 112/75. So this can be a common complaint for erectile dysfunction. You can treat it with phosphodiesterase inhibitors like sildenafil or Viagra, and there's an absolute contraindication while taking any nitrates or ryaglutide due to actions on GMP, the secondary messenger pathway. So phosphodiesterase inhibitors will stop the breakdown of cyclic GMP, and nitric oxide will increase the production of cyclic GMP. So acting both sides on the pathway can result in abnormally low blood pressure, and it's difficult to respond to that. So next up we have prostate cancer. We've got a 68-year-old black man who complains of dysuria and progressively increasing urinary frequency. He also has back pain and weight loss that has lasted for several months. On prostate exam, a nodular, rock-hard, irregular area of induration is felt in the prostate. So your next best step when you're worried for prostate cancer is a transrectal ultrasound with biopsy, and you're looking for the Gleason scale. PSA is a good diagnostic tool for tracking disease progression after diagnosis, but it's rated as a class D for USPF-TF in terms of screening. You can treat this with a prostatectomy with radiation. You can do orchiotomy, lupriolide, or anti-androgens such as flutamide. And you want to be careful because it likes to met locally to the bones, like the spine and pelvis, with osteoblastic lesions. So bladder cancer. We've got a 76-year-old who comes to the doctor for progressively darker, reddish urine. He's had a 50-pack year smoking history, but has recently quit, and he retired from a chemical dye factory. Vital signs are blood pressure of 141/83, pulse of 81. On exam, there's no flank pain or mass, and rectal exam is unremarkable. So bladder cancer is within the differential of RCC, like we had learned. So the next best step here is urinalysis and cytology. The definitive test would be a cystoscopy and biopsy. So the risk factors are smoking, and then if they happen to work in an industrial dye like aniline or azo dyes, or if they've had a history of cyclophosphamide treatment for like a Goodpasture's disease, for instance. What you're going to want to do is treat surgically and remove it depending on the stage, and watch for recurrence because this is a transitional cell cancer and it commonly recurs. So next up, moving into testicular pathology, we've got epididymitis and mumps. So a 28-year-old man presents with gradually worsening scrotal swelling and pain. He's sexually active with multiple partners, and he reports pain on urination and ejaculation. On physical exam, there is scrotal edema, and the epididymis is enlarged and tender. Elevation of scrotum relieves the pain, or Nell's sign. So the diagnosis is epididymitis, and the next best step is urinalysis with culture and NAT testing, because the common bugs in a sexually active under 35-year-old, just like prostatitis, is going to be GC chlamydia. In older individuals, it is E. coli or Pseudomonas. So the treatment is antibiotic therapy directed at the urine cultures. So last, we've got an unvaccinated 18-year-old daycare worker from California who presents with fever, malaise, and parotid swelling. So this is a mumps case. So mumps orchitis is associated with loss of fertility, and you can prevent this with a helpful vaccine called the MMR. Next up, we've got testicular torsion. So a 19-year-old male is brought into the emergency room because of sudden onset severe pain in the lower abdomen and scrotum while running. Vital signs show normal temperature, elevated pulse and BP, and respirations of 21. On exam, his right testicle is diffusely tender, swollen, and elevated with a negative Pren sign, so there's no cremasteric reflex, and it does not improve pain with elevation. So the diagnosis would be a testicular torsion. The next best step is testicular ultrasound with Doppler to confirm the loss of blood flow. The treatment is emergent surgery, so you would try detorsion and fixation because they're at risk to recur. The risk of necrosis after 4 hours is evident, so treatment needs to be acute. Next up, we've got a 14-year-old boy who presents with gradual onset of testicular pain. On exam, there is a blue dot evident with non-painful inguinal lymphadenopathy. So this is torsion of the testicular appendix. It's associated with viral infections and inguinal lymphadenopathy. You want to treat with NSAIDs and ice. So last, we've got testicular cancer. So a 36-year-old white male presents with progressive painless enlargement of the left testicle for 2 months. He's also complained of a sense of heaviness in his scrotum. On exam, there is a peanut-sized, non-tender, smooth, firm mass at the upper end of the left testicle that does not illuminate. The next best step is radical orchiectomy. If you do an FNA, it risks seeding the tumor, so radical orchiectomy is recommended. Imaging is indicated for metastases, so seminomas are very radiosensitive, and they like to metastasize to the lung areas. And then non-seminomas respond well to chemotherapy. So it's important, any male between 20 and mid-30s, to screen with testicular exams and to make sure to treat aggressively if they have a complaint. So we're moving into the acid, base, and electrolyte section. Some of the learning objectives are to determine primary acid-base disorders and differentiate causes of anion gap metabolic acidosis and non-anion gap metabolic acidosis, to manage fluid and sodium disorders, and to diagnose electrolyte abnormalities and characterize their EKGs, and then to recognize toxidromes and apply their antidotes to common toxicities. So if you wanted to do acid-base calculations, there are not many that you would need to do on your shelf or step exams. But if you start with the pH, anything less than 7.5 is acidic, greater than 7.45 is alkalotic. So you check the bicarb and the sodium. Normal values are 24 and 40 respectively. If the bicarb is low and the CO2 is high, that's going to be a metabolic acidosis. Next step is you can calculate the anion gap. You do sodium minus bicarb plus chloride. Any anion gap that is greater than 12 is considered an anion gap metabolic acidosis, and you can do the mud piles mnemonic to figure out the common differential for this. If the anion gap is less than 12, it is a non-anion gap metabolic acidosis, and there's a mnemonic hard up for the most common causes of that. If the bicarb is high and the CO2 is low, that is a metabolic alkalosis. So the extra step here is to check urine chloride. If the urine chloride is greater than 20, it predicts a renal cause. Think Conn syndromes, Barter's, or Gittleman syndrome. If the chloride is less than 20, it predicts an extrarenal cause. Think GI upset like vomiting, nausea, NG tube suction, antacids, or diuretics. If the CO2 is low and the bicarb is low, it's a respiratory alkalosis. So hyperventilation from anxiety is the most common cause, elevated ICP, fever, pain, and salicylates. If the CO2 is high and the bicarb is high, it is a respiratory acidosis. So hypoventilation from opiate overdose or brainstem injuries. So if we look at our AGMAs, so we have a 57-year-old man with prediabetes who's admitted to the hospital for sepsis. Vital signs show a BP of 87/59, a pulse of 135, and a temperature of 38.5. On exam, he appears flushed and diaphoretic, and there is a small cut on his leg with surrounding erythema. Admission labs include blood cultures and antibiotics are ordered, and he's found to have a bicarb of 15 and an anion gap of 23. So your next best step here is to do an ABG and a lactate, and you can predict his expected PCO2 using the Winter's formula, or 1.5 times the serum bicarb plus 8 plus or minus 2. So your causes of the anion gap metabolic acidosis here are mud pilers. So methanol and metformin, uremia, diabetic ketoacidosis, paraldehyde or propofol, iron isoniazid or isopropyl alcohol, lactic acidosis, ethylene glycol toxicity, rhabdomyolysis or renal failure, and salicylates. So the treatment is going to be to determine the underlying cause and to address, and watching for respiratory fatigue. So for your NAGMAs, you've got a 25-year-old world traveler with GERD who is admitted for gastrointestinitis. So she complains of profuse rice water stools and has just returned from a country endemic with cholera. Vital signs are notable for a temperature of 37.8, pulse of 108, and BP of 106/67. On exam, there's diffuse cramping with no guarding of the abdomen. There is increased skin turgor with delayed capillary refill. Your next best step is bolus of normal saline. If you're looking at the cause of the NAGMA, hard up is your most common mnemonic, so hyperalimentation or hyperchloremia, Addison's disease or acetazolamide, RTAs, diarrhea, or some common surgeries like a Whipple surgery or a Florida pouch. So to treatment, you need to determine the underlying cause and address it. In this case, it's judicious fluid resuscitation from the cholera infection. Now we've got a case of metabolic alkalosis. So a 23-year-old is admitted for intractable vomiting for the last 6 hours. He has no past medical history, but admits to smoking a lot of weed. The only thing that has helped his symptoms is a hot shower, but they recurred after he lit up again. Vital signs are stable, and initial exam is benign. Laboratory values show a serum bicarb of 33. So your next best step with a metabolic alkalosis is to check the urine chloride. Causes can be vomiting, NG tubes, colonic polyps, Conn syndromes, Cushing syndrome, or renal tubular disorders. The treatment is going to be volume resuscitation with normal saline, or contraction with spironolactone to save the potassium. So hyperemesis cannabinoid syndrome versus cyclic vomiting is shown here. So hyperemesis cannabinoid syndrome is frequently associated with smoking a large amount of cannabis, and then the only thing that seems to relieve the issues is going to be a hot shower. It's important to counsel them not to smoke extra. It's thought to be a buildup of the cannabinoids in the body. Cyclic vomiting syndrome is also related to this, not related to cannabinoids in general, but it's also an intractable vomiting syndrome. Next up, we've got respiratory alkalosis. So we've got a case of a 23-year-old medical student who's got a feeling of impending doom and anxiety every time a 4-letter examination is mentioned. He feels lightheaded, dizzy, and even has occasional nausea. Vital signs are BP of 128/74, pulse of 119, and respirations of 28. The next best step is reassurance and inhalation into a paper bag. So a lot of causes of respiratory alkalosis are anxiety, PEs, asthma, pregnancy. There's a baseline increase in respirations due to the defect of the diaphragm. And there's cirrhosis, aspirin overdose, and mechanical ventilation. The treatment is to correct the underlying disorder or reassurance in terms of pregnancy. For respiratory acidosis, we've got a 39-year-old with a history of myasthenia gravis who's rushed to the ED for respiratory distress. She has had difficulty filling her prescriptions, and a recent heat wave exacerbated her condition. Vital signs show a BP of 112/64, pulse of 57, and on exam, pupils are normal and reactive. The next best step for this patient would be intubation and mechanical ventilation. So causes of respiratory acidosis are drug intoxication like heroins, opioids, benzos, OMI, COPD, and neuromuscular diseases such as MG, or brainstem injuries. So to treat the underlying disorder and correct any reversible causes, so give naloxone to everyone who comes in the door. Otherwise, intubation may be required. Moving into electrolytes, hyponatremia. So a 78-year-old post-op patient is turfed to medicine after she was found to have a sodium of 127 on post-op day 1 from a right hip arthroplasty. She had an uncomplicated surgery for which she was given tramadol for pain, and she's had one episode of agitated delirium, which she was given haloperidol. She has a history of anxiety, and she takes fluoxetine. On exam, her mucous membranes are moist, and there's no JVD or edema appreciated. So it appears that she's euvolemic. So the next best step is to measure serum osmolality, followed by urine osmolality and sodium. So if you have somebody with hyponatremia, so serum osmols less than 280, you can look at hypovolemic, so they can be divided into their urinary sodium excretion. Somebody with low urinary sodium retretion who's hypovolemic could be due to compensation for diarrhea, vomiting, NG tube suction, diaphoresis, third spacing, pancreatitis. These are fluid losses, and your body is trying to compensate for that. If there's high sodium release, it can be due to diuretic excess or decreased aldosterone and acute tubular necrosis. So this is when your body can no longer compensate because there's some extrinsic pathology going on. Say this person, for instance, in this case is euvolemic. They've got moist mucous membranes and no JVD. You can think of classically SIDH, psychogenic polydipsia, and postoperative hyponatremia. Hypothyroidism, oxytocin, haloperidol, cyclophosphamide, SSRIs are common drugs that can cause this. If they were hypervolemic, say somebody had edema, JVD, you can think CHF, nephrotic syndrome, kidney failure, and liver disease of holding on to too much fluid, so you're diluting the amount of sodium. If they were hypertonic hyponatremia, this is increase in osmotic pressure, so the water flows out of the cell, causing a dilutional hyponatremia. You can think of something like hyperglycemia causing that. So DKA and HHS are common causes where there's so much glucose in the blood that they extract water and thus dilute the amount of sodium that is there. And then mannitol, sorbitol, glycerol, maltose, and radiocontrast are all extra things that can be dissolved in the blood and thus extract water and cause a dilutional hyponatremia. So your treatment, if you've got mild hyponatremia between 120 and 130, is to try water restriction to rebalance it. If there's moderate, like 110 to 120 sodium, try loop diuretics and normal saline. And then if there's severe hyponatremia, less than 110, or they are symptomatic, either due to seizures, altered mental status, hypertonic saline to increase their sodium by 1 to 2 milliequivalents per liter per hour until their symptoms improve. The risk of increasing their sodium too much is central pontine demyelinization. So how you can remember this is low to high, the pons will die, high to low, the brain will blow, or edema. So for instance, here we're going low to high, and the pons will die from central pontine demyelinization. Into hypernatremia, we've got an 18-year-old woman in a motor vehicle accident who strikes her head against the steering wheel. She's treated in the ED and discharged with minor bumps and bruises. 1 week later, she begins to feel very thirsty, and she's always going to the bathroom. Her vital signs are BP 118 over 68, a pulse of 95, and temperature of 37.1, respirations of 18. On exam, there's dry mucous membranes. So the next best step here is to look at urine osmolality and sodium. For the treatment and causes of hypovolemic hypernatremia is more water loss than sodium loss in the kidneys. This is commonly due to diuretics, glycosiuria in somebody with uncontrolled diabetes, renal failure outside the kidney due to diarrhea, diaphoresis, and respiratory problems. You can treat with normal saline to restore the plasma volume, and then D5 to correct the amount of sodium. If there is euvolemic hyponatremia, look for diabetes insipidus. The treatment is to hold fluids and give vasopressin to differentiate between central versus nephrogenic diabetes insipidus. You can treat central diabetes insipidus by giving them the hormone that they've lost, desmopressin, or nephrogenic diabetes insipidus with increased water and thiazide diuretics. It sounds counterintuitive, but that's the treatment. If there is hypervolemic hypernatremia, this is due to excess sodium caused by us, like iatrogenic injuries, or exogenous glucocorticoids like Cushing syndrome and hyperaldosteronism. You can treat with loop diuretics and D5 or dialysis. So, like we mentioned earlier, you don't want to correct more than 12 milliequivalents per day due to cerebral edema. The brain has fluid shifts as well. If you change the sodium concentration, you can have too much fluid rush into the cells and cause edema and swelling in the brain. Moving into potassium, hypokalemia, we've got a 67-year-old with CHF who's admitted for muscle cramping, fatigue, nausea, and emesis. He's on an ACE inhibitor, furosemide, and digitalis for his CHF. Vital signs are pulse of 67, BP of 124 over 78, and temperature of 37.1. On exam, there is decreased bowel sounds. Laboratory studies show a potassium of 3.1, and EKG is shown below. If you look closely, you can see those classic U waves or a biphasic T wave. The next best step is digitalis level and potassium repletion. So causes from extrarenal are usually due to vomiting, NG tubes, fistulas, diarrheas, and laxatives. If it's a renal cause, think of diuretics, RTAs, Conn syndromes, Bartner syndrome, or Cushing syndrome. The treatment is going to be oral or IV replenishing, and you can add lidocaine in the IV because it can be very painful. The max is 10 milliequivalents per hour peripherally and 20 milliequivalents per hour in the central line. You don't want to cause ventricular arrhythmias by adding too much potassium too quickly. You can check magnesium, otherwise it will be difficult to correct if the magnesium is low as well. For hyperkalemia, we have a 19-year-old new Army recruit. He's found down after morning PT. He complains of muscle weakness, nausea, and vomiting. Vital signs are stable. On exam, there's a decreased deep tendon reflexes, and laboratory study shows a potassium of 6.5 and a CK of 867. Next best step here would be an EKG. Hyperkalemia is very dangerous. It can cause a lot of ventricular arrhythmias. The EKG shown below shows peak T waves, very tall and pointy T waves. So some causes of hyperkalemia are renal failure, Addison's disease, drugs like spironolactone and ACE inhibitors, especially when combined. Acidosis increases your potassium because there's a hydrogen-potassium exchanger, and then rhabdomyolysis or blood transfusions. Treatment acutely, you want to stabilize the cardiac membrane with calcium gluconate, so you can give an amp of that immediately. And then in the short term, to hide the potassium, so to speak, you can give insulin in D5, which will take the sugar and the potassium, and the insulin imports that into the cell, gets it out of the periphery. You can also use albuterol or sodium bicarb. Long term, you're going to want to use K-oxalate or loop diuretics or dialysis to remove it permanently from the body. Going into calcium, we've got a 47-year-old woman who develops numbness and tingling around her mouth and in her fingers and toes. 1 month ago, she underwent an uncomplicated thyroidectomy for Graves' disease. Vital signs were normal, and physical exam is relevant for twitching of the facial muscles when her cheek is tapped. Laboratory studies show a calcium of 8.1, and then the EKG shown here shows a prolonged QT. So your next best step is ionized calcium. Causes are going to be iatrogenic pancreatitis, because you're going to get dystrophic calcification within the pancreas, renal disease, hyperphosphatemia, pseudo-hypoparathyroidism, hypomagnesemia, vitamin D deficiency, blood transfusions due to the citrate that's within the blood. It can bind to the calcium, and then DiGeorge syndrome or congenital absence of the parathyroid glands. You can treat with calcium gluconate when symptomatic. Calcium supplementation and vitamin D is the long-term treatment, and you want to check magnesium as well, otherwise it can be difficult to correct your calcium. More details on secondary and tertiary hypoparathyroidism treatment are in the endocrine section. So for hypercalcemia, we've got a 57-year-old woman with a history of metastatic breast cancer who develops acute abdominal pain that radiates to her groin. For the past week, she has felt more aches and pains in her bones and muscles, and she's been more constipated despite her refusal to take opioids for her cancer pain. She has tried to stay hydrated and finds herself going to the bathroom all the time. On exam, her vital signs are within normal limits, and her exam is unchanged. Her laboratory values show a calcium of 14.2, and an EKG is shown below. Her next best step would be vigorous fluid resuscitation. So hypercalcemia, the most acute thing that you want to do is dilute the calcium with fluids before you try to treat it with loop diuretics to remove the calcium with calcium wasting, or bisphosphonates and calcitonin to stop the production of calcium. Causes are hyperparathyroidism, renal failure, malignancies, multiple myeloma and milk alkali syndrome. Thiazide diuretics will also raise your calcium, and sarcoidosis. So hypo and hypermagnesemia, we've got a 48-year-old with short bowel syndrome who's admitted for failure to thrive. He has weakness, muscle twitching, and tremors. On exam, there is increased reflexes. Laboratory studies show hypokalemia, hypocalcemia, and hypomagnesemia. So this is going to be due to malabsorption. It can also be seen in alcoholism, renal failure, Bartter syndrome, SIDH, or diuretics. The treatment is oral magnesium or parenteral magnesium, and then you can correct hypokalemia and hypocalcemia after. Lastly, we've got a 25-year-old G1 P0 woman at 37 weeks. She's being treated for preeclampsia and is induced to labor. Following delivery, she's unable to move her face. Vital signs are stable, and exam shows deep tendon reflexes that are absent. So the most common cause of hypermagnesemia is iatrogenic. So they use magnesium as a treatment for torsades, but also to prevent eclampsia. There's also renal failure, burns, laxatives, or Addison's disease. The treatment is calcium gluconate acutely, and then IV fluids and loop diuretics to dilute the hypermagnesemia and waste magnesium. And you want to monitor for respiratory failure. That's the feared complication of hypermagnesemia. So moving into the intoxication lightning rounds, these will be quick toxidromes with a diagnosis and the reversal agent or treatment. So we've got an 18-year-old man brought into the ED being found on the street unresponsive. He is lethargic and he does not answer questions. Vital signs show a BP that is normal to low, pulse of 56, and respirations of 8. On exam, his pupils are pinpoint and not reactive. There are track marks on his arm. So this is a classic heroin overdose. So you want to look for pinpoint pupils. You want to look for low BP, low pulse, low respirations. And the treatment for this is naloxone. A lot of the times they'll have multiple doses before they even reach the ED. Next up, we've got a 67-year-old who's brought to the ED after fainting at church. Earlier in the morning, she complained of dizziness and dyspnea. Vital signs show a BP of 85/60 and a pulse of 52, respirations of 18. On exam, lung fields have scattered wheezing, and EKG shows a normal QRS, but a P to R interval is increased. So this is beta blocker toxicity. They're going to have low BP, low pulse, but their respirations are unchanged. They usually don't have any risk factors for heroin or opioid overdose. They can have wheezing because of the beta blockade within the lungs. And then EKG would show the PR interval increasing. Your treatment is glucagon for beta blocker overdose. And you want to treat the bradycardia with atropine or epinephrine, the bronchospasms with bronchodilators, and the hypotension will respond to fluids. Now we've got a 16-year-old coming into the ED after they were found in the garage with slurred speech, lethargy, and vomiting. Vital signs show a pulse of 108 and a BP of 92/48. On exam, the patient's abdomen is non-tender. Laboratory studies show an anion gap metabolic alkalosis with normal glucose and elevated BUN creatinine. UA shows hematuria and crystals. So the diagnosis here is ethylene glycol poisoning or antifreeze poisoning. That's why he's found in the garage. There's lethargy and vomiting because of the gastrointestinal effects of it. You want to look for an anion gap metabolic alkalosis along with kidney failure, kidney stones, or hematuria. The treatment here is ethanol or fomepizole to saturate the alcohol dehydrogenase, and then dialysis can be used. Next up, we've got a 27-year-old female admitted with high fever and muscle rigidity. The patient's mother reports that she began treating for schizophrenia. Vital signs show a pulse of 167, BP of 108/57, and temperature of 38.7. On exam, the patient is confused, diaphoretic, and has marked rigidity of all muscle groups. Labs show a leukocytosis and an anion gap metabolic alkalosis and elevated CK. So this is neuroleptic malignant syndrome, a feared complication of a lot of antipsychotic medications. You want to look for hypotension, elevated pulse, diaphoresis, and rigidity of their muscle groups. Leukocytosis is a good differentiating factor between malignant hypertension and neuroleptic malignant syndrome. They can get an anion gap metabolic alkalosis and elevated CK from rhabdomyolysis. The treatment is dantrolene along with benzodiazepines. Now we've got a 19-year-old who's brought into the emergency room after intentionally ingesting a family member's pills. He complains of abdominal pain and diarrhea. He's had 2 episodes of bluish-green emesis followed by a large hematemesis. Vital signs show a pulse of 120 and a BP of 90/50. On exam, his abdomen is tender to deep palpation with no guarding. Black stool is present on rectal exam, and labs show a metabolic acidosis with elevated anion gap. So the diagnosis here is iron toxicity. It can be seen as radiopeg tablets within the stomach, shown to the right. It's going to cause a lot of GI or intestinal upset as well as intestinal bleeding. And then there's an anion gap metabolic acidosis from the iron. You want to treat with IV fluids and chelation therapy with deferoxamine. Gastric lavage or induction of vomiting is still debated over a lot of ED physicians. So, moving on to a 35-year-old who presents with severe nausea, hematemesis, and abdominal pain. He's otherwise healthy and takes no medications. Vital signs show a BP of 128/83, pulse of 98, temperature of 37.2, and respirations of 26. On exam, he appears flushed and disoriented. His abdomen is soft and there's no guarding apparent. Laboratory studies show an anion gap, but the patient is non-acidotic. So this can be a salicylate toxicity or acute aspirin ingestion. So they have a lot of hematemesis and abdominal pain, and usually they will show an anion gap metabolic acidosis. This patient is non-acidotic because at first there is a compensatory respiratory alkalemia. So the treatment is antacids, alkalizing the urine, and aggressive charcoal, and dialysis if the aspirin levels are dangerously high. Next up, we've got a 28-year-old who's admitted for observation for being drunk and agitated. The patient was diagnosed with MDD and borrowed her friend's antiemetic medication that morning to deal with a hangover. Vital signs show a pulse of 110 and a BP of 147/93, respirations of 24 and temperature of 39. On exam, she appears disoriented, aggravated, and diaphoretic. Her neurological exam reveals hyperreflexia and a resting hand tremor. So the diagnosis here is serotonin syndrome. They were probably taking an SSRI and borrowed their friend's antiemetic or ondansetron. You can treat with cyproheptadine and external cooling, IV fluids and benzodiazepines for agitation and seizures. And serotonin syndrome culprits are SSRIs, dextromethorphan, tramadol, ondansetron, linezolid, and illicit drugs like cocaine, LSD, Molly, and ecstasy. So last up, we've got a 25-year-old who's rushed to the ED after his friends found him altered with a suicide note. The patient complained of palpitations, dry mouth, blurred vision, and feverish. Vital signs show a pulse of 138, BP of 102/67, and temperature of 37.9. On exam, his skin is warm and dry, and EKG is shown below. So this is a classic anticholinergic toxidrome. And then on the EKG, you can see widening of the QRS, which is common in TCA overdose. The treatment here is sodium bicarb bolus and supportive care. Next up, we've got a 43-year-old migrant worker who's brought to the ED after he was almost struck by a crop duster. The patient complains of dry mouth, blurred vision, and diarrhea. Vital signs show a pulse of 148, a BP of 108/61, and a temperature of 38.2. On exam, his skin is warm and dry. Abdominal sounds are not heard. So this is also anticholinergic, caused by organophosphate poisoning. The treatment is pralidoxine and atropine, and removal and dispersion of the clothing and washing of the body. Organophosphates like serine are used in chemical warfare. And the treatment is going to be pralidoxine. Next up, we've got an 18-year-old honors student who's brought to the ED by police around final exams because of marked restlessness, euphoria, anxiety, paranoia, and agitation. The patient has a history of ADD. Vital signs are BP of 118/112, pulse of 156. On exam, he's diaphoretic and tremulous. Laboratory studies show a negative urine toxicology screen. Diagnosis is amphetamine or bath salt toxicity. So the treatment is going to be benzodiazepines for the agitation, any seizures and coma that could result from it, and the hypertension is best treated with a vasodilator such as nitroprusside, and acidification of the urine can help with removal of the agent. Next, we've got a 30-year-old man who's brought to the ED from a park in a stuporous state. He's got nausea, protracted vomiting, jaundice, and malaise. On exam, there's noticeable icterus and asterixis. Labs show an elevated serum transaminases, bilirubin, and prolonged PT. Diagnosis is most likely acetaminophen toxicity in a young man. The treatment can be N-acetylcysteine to help replete the hepatic glutathione levels, supportive care and management of fulminant hepatic failure. Liver transplantation evaluation should be considered as well. Lastly, we've got an 18-year-old in her mother's medication cabinet during a party. Her vital signs show BP of 104/71, pulse of 65, respirations of 7. On exam, her pupils are pinpoint and minimally reactive. She's lethargic with poor inspiratory drive. Diagnosis here would be benzodiazepine toxicity. Treatment is flumazenil for acute intoxication, not for any chronic users. This can throw them right into withdrawal and thus a seizure if they're dependent on benzodiazepines. You also want to monitor their airway and prepare to ventilate if needed. So this marks the end of the electrolyte and intoxication section. Next up, we've got GI and liver, biliary.
I am Professor Patrick.
Professor?
Dr. Professor Patrick.